Hi, everybody. Hi. Much better. Thank you. Thank you. And good evening again and again. Thank you, everybody, for coming down here. Tonight's program is different than we've done in the past, and I'm sure you're going to really appreciate what Patricia is going to be able to, offer back to you all for this. Beginning tonight, I want to thank the company that supported us to do tonight's program. There was only one. Normally we have a few out there, but fortunately we had one tonight, and that is Celgene, and I hope everybody can appreciate what they did tonight. Give them a round of applause, please. In addition, though, to Celgene, we had a lot of exhibitors, as you saw when you were coming in. And so we had Mallinckrodt, okay? We had Metro Infusion, Biogen, Genentech, and EMD Serono. And I hope that you could all appreciate them for being here tonight, because they, too, supported what we're able to do with this program tonight. We have, again, Patricia Pagnotta, who's also known as Trisha Pagnotta. But I've never called her Trisha, only Patricia. Right? There you go. All right. Trisha Pagnotta, oops, I just said it, is Master's Prepared Nurse Practitioner. Is that an associated nurse practitioner? How do you say the A word? Associated nurse practitioner. Advanced nurse practitioner. I've asked so many people that, and they haven't told me that. Let's start again. Trisha Pagnotta is Master's Prepared Advanced Nurse Practitioner, and has been a nurse since 1981. She's originally from Baltimore, Maryland, and a graduate of the University of Maryland. Patricia has been an active international organization of MS Nurses member since 2006, and let's give her a round of applause. She's their current president. Trisha is very active in education of peers and patients. She organizes and participates in her center's monthly MS support group meetings. She's an active researcher and participates in her center's research of emerging therapies, and has published as a primary investigator in MS trials. Let's welcome Trisha Pagnotta. By the way, hold all your questions for the end. We're going to run around the room after she does her presentation, and we'll take the questions, and she'll answer them. Very good. It's only one way up. All right. You're going to use this?
Yeah.
Great. Perfect.
I guess I'll use this.
Thank
Okay.
you.
All righty. Thanks so much to everyone for coming out. And usually I introduce myself, and I don't say so many things. I use very few words. But the other thing is I usually tell persons, but since Stuart said questions at the end, I usually tell persons I'm here because of you, and I really do want you to get the information. Every time when Stuart asks me to speak, he gives me a list of things that I could spend all day talking about. And we agree on something and come back, here comes the list again. So I tried tonight to make the slides rather simple, because I do want you to be able to get what you came for, not my slide presentation, but the things that are in you and that you want to talk about. So hopefully I'm just going to warm you up for some good conversation. And when I'm done speaking the presentation, then again, we'll have question and answer. So, and I couldn't decide what to call this, so Karen MS. All right. So what is multiple sclerosis? I think that this is something that is extremely important that we keep revisiting, because I often have persons who have been diagnosed, who have not been diagnosed, who have no clue what this disease is. But for those of you that have been diagnosed, this is a chronic, lifelong disease. It's a disease of your central nervous system. Then the central nervous system is your brain, your spinal cord, and your optic nerves. What happens is you get damage of the myelin covering of the nerve, and that is what causes those scars, multiple scars. This is an immune-mediated disease, so it's important to understand those critical elements. When we look at what is happening in MS, your central nervous system is full of neurons, and these neurons talk to one another. It's a big electrical system, and you see this is a beautiful, healthy neuron. You see the body, and then the tail, and goes to another body. And this makes it look very simple, like there's just one little thread that goes through. It's not at all that simple. There are millions of threads that go through. But it is an electrical system. It is the changing of energy, the passing of energy from one nerve cell to another to communicate. And what happens in MS is you get the immune system gets into your central nervous system and starts acting differently. It doesn't recognize you as not being something foreign. So specifically, your neuron, your covering, it starts eating away at that. And so what can happen is you get scars. Sometimes you can get whole cutting of that nerve, so that nerve then cannot communicate with the next nerve body. That is the crux of what all of your symptoms come from, is this process. When there is inflammation, we're talking about the acute attack when things are happening and cytokines are being released. And when we can see on MRI, we see something that enhances, that's inflammation. And we know that for most persons, inflammation is the bigger part of this disease. But we also know that neurodegeneration, irregardless of what type of MS you have, neurodegeneration occurs from the onset of this disease. So many times before you even have a clinical attack or have any clue that you have MS. So neurodegeneration really speaks to that process where nerves are dying and they're not able to participate in the communication. Bigger way of calling that is atrophy. So we know that that happens, and it's just a shift in when we look at different phenotypes of MS, how much is inflammation and how much is degeneration. But knowing that both of them are always happening at the same time, and it's the shift of the balance, which is occurring more. And obviously, if you could plan out your life with MS, you'd want to say, I want to have more inflammation than degeneration. And so the key there is early treatment, if you can recognize and treat early. So I talk to persons about my favorite subject is the report card for MS. And so I like to make things simple. Who hasn't gotten a report card in this room? I think everybody's gotten one. And so when I tell persons about what is it that's important, we talk about different subjects. The subjects are relapses, disability, MRI activity, and adherence. Now, these are just listed up here. I tried to think about, okay, what kind of word can I make with this? And I just gave up. But they're just listed here. I would tell you that probably relapse is going to be the thing that draws your attention first, because that's what most of the time brings a person into a clinic to think about diagnosis. Not always. Sometimes we see persons that had a motor vehicle accident and they get an MRI and, oh, they've got these things in their brain. But most of the time, it's some neurologic symptom that has occurred and that got a person into our office. The very next thing is adherence. You think about, whoa, what does that mean? That means your ability to think about where you are, to take control of the fact that this is a chronic neurologic degenerative disease, and for us to make the best for you, you need to be able to adhere to whatever the program is. And so that's important, and you have to be involved. Disability, every person I see who has multiple sclerosis, no one has ever said to me that they don't want to become disabled. In fact, that's usually the first thing that persons say to me is, I don't want to be disabled. And so that's another thing to look at on the report card. And then MRI activity. It's extremely important that we look at all four of these things in measuring how well a person is doing with their multiple sclerosis. We know through studies that MRI activity is occurring even when persons think they're doing very well. So MRI activity, regular surveillance of your MRI is important. Really being able to talk about your disability. and telling your provider if you have a relapse. So the MS symptoms are numerous. They're interrelated. I bet you every single one of you can relate to at least one of these things on the slide, even care partners. Because, you know, as I look up here, I'm thinking to myself, pain. I've had pain before. Fatigue. Well, tomorrow morning I'm going to be a little bit tired. So persons, these symptoms happen to other persons. So one of the things that when we're start talking a little bit later in the program, think about MS is not a common disease. These are symptoms that can be from MS, but they can also be from other things. So think about that. But if you have these symptoms, these are the type of things that you and your healthcare provider will be focusing and talking about. To treat a person who has multiple sclerosis successfully requires a village. Comprehensive care is something that both the IOMSN and the CMSC are very, very strong advocating for. And so persons who see healthcare providers should see healthcare providers that send them to everyone that they need. So you may, in your healthcare provider's office, have both a neurologist, a nurse practitioner. You may have even a nurse. You may have a physician's assistant. You may have a medical assistant. There may be speech therapy, occupational therapy, or physical therapy in the office. And maybe they're not in the office, but they have a connection of where they send you to. Urologist, pain management doctors, ophthalmologist, social workers, all of these individuals are extremely important that you're able to tap into these. And MS Views and News recognizes that they have their free social work service because that is a very unmet need in MS. And so if you don't know about that, please go to the MS Views and News website. They do have a free social worker that you can connect with. So again, it takes a village to take care of persons successfully. So what is a relapse? I was not going to include this in the slide deck tonight. And yesterday, I saw a person who I had been seeing for quite a while. And she came in and told me, you know, I think I may have had a relapse. Okay, so I'm expecting she's going to tell me about symptoms she's currently having. No, she wanted to tell me about symptoms she had had 2 months ago. Please, think about what I'm about to tell you, what a relapse is. But think about, more importantly, it is not your job to be your healthcare provider. It is your job to know when something is not what is normal for you, and you to tell your healthcare provider about it. If you don't have that relationship with your healthcare provider, you need to find it. And you know, I know that some of my patients say, well, you're so busy and I'm so busy. Well, you can connect with me in many ways, but you can connect with your healthcare provider. The issue is you need to be taken care of. So what is a relapse? New or worsening symptoms. So it doesn't have to be something brand new worsening. It could be something that you've had before that has gone away and now it comes back. It must last at least 24 hours because we know things that don't last 24 hours are not new things that are occurring in your central nervous system. It cannot be related to any other cause. So I did see that they lowered some of the screens over here and the sun is going down, but the poor persons that are sitting right over there as the sun is hitting your back, if you get a little bit warm, might it be possible that some symptom of yours happens? Well, that would not be a relapse. But so again, and when we talk about relapses, we separate them by 30 days. So that's something else to think about because persons will talk to me, I've diagnosed them with a relapse, we're treating that relapse. And I thought I was going crazy. And then symptoms will get worse. Or something new will happen, but it's still within that 30 days. And so persons may not call, or persons may think, well, it's still the same relapse. Again, we want to make things better. So if things are not going along as they should, make sure you talk to your healthcare provider about that, because as I like to explain to persons, when you're having a relapse, there's a fire going on in your central nervous system. And we want to put that out. If we just take those ashes and we have them smoldering and don't get them out really well, that fire could re-erupt and you could have more symptoms. So it would be extremely important for us to continue treating if that's occurring. So what would not be a relapse? If the sun's coming in, hits your back, and you're getting nice and warm, and you start having blurring of your vision, if suddenly you forget somebody's name. I know that person's name. I've been seeing that person. I can't remember their name. And then, a few minutes later, you stumble on another word. Is that a relapse? No, it has to be something that lasts 24 hours, can't be caused by something else, can't be caused by heat, can't be caused by stress, sickness, medications. If you just started a new medication, that can oftentimes cause many neurologic symptoms. If you were to go into any drug list, they tell you the first, several symptoms of many drugs is dizziness, nausea, headache. So it could be a drug. Did you drink alcohol? Is it possible that it's alcohol related? Either you're under the influence, or the next day you're after the influence and you're extremely dehydrated and it's hard to move around. Poor sleep. So those are some of the things that would not be considered relapses. We call them pseudo, meaning false relapse, or UTOS phenomena. How do we treat relapses? Well, the goal really is to bring you back to a resolution of those symptoms that you're having as quickly as we possibly can, to support an environment for healing. So the one thing is to put that fire out, and then the other is to help you with brain plasticity. So we put the fire out by giving things like steroids, Athgar, IVIG, plasmapheresis. We help with plasticity by getting therapy going, physical therapy, occupational therapy, speech therapy. Those things for whatever your symptom is, to get your central nervous system working again and thinking, okay, I've got to make that connection. So that's important for treating a relapse. Now we're going to move on to some statistics, and since this is supposed to be partially a women's program tonight, I thought I'd put up the women's statistics. Predominantly, this is a female-dominated disease. So there's 3.5. It's up to 3.5 now for every one man. 3.5 women for every one man. We know that most of the time females are diagnosed earlier. We know also, thankfully, they have less progression as a whole, and they have a lower prevalence of going on to have primary progressive MS. So you could turn this all around if you're the male sitting in the room. Familial reoccurrence, there's 15% higher for first generation. So if mom has it, then first generation would be daughter. And in identical twins, the prevalence is only about 25%, that if one develops MS, that the other one will. So you see that there is some genetic influence, but there's not a direct genetic link. Otherwise, the identical twins would be 100%. When we talk about routine health screenings, it's very important that women are getting their routine health care. I tell persons you really should have a primary care doctor. You should be seen for things other than your MS. And, again, we're looking at this disease. Most persons are diagnosed early, and many persons early do not have regular primary care doctors. So it's important that you are thinking about that. So routine health screening should include breast cancer screening, cervical cancer screening, colon cancer screening, screening for osteoporosis, and depending upon your steroid use, you and your primary care or your GYN should be talking about whether or not you should be screened earlier for osteoporosis, because we know that that is a side effect of steroids. Hepatitis C, HIV, and lung cancer. These are things that should be screened on a regular basis. Routine annual screenings that should occur annually. Check for depression, diabetes, high blood pressure, high cholesterol, obesity, sexually transmitted diseases, and immunizations. Okay, so every time you see your primary care doctor, they should be asking about these things. So what are the MS symptoms that women have frequently? Well, we also win the lottery game as far as headaches go. 1 in every 4 women are going to suffer from headaches. And headaches are the #1 reason for persons to seek health care in the United States. So persons going into any health care, whether it's a primary care doctor's office, GYN, neurology, ER, the #1 reason is headaches. Then women have the special of pre- and postmenopausal issues, contraceptives, and then osteoporosis. So these are the things that we have that are special. When we talk about headaches, again, the most important thing, as with any of your MS symptoms, is thinking about the fact that we'd like to have lifestyle modifications be one of the things that is first and foremost, because is it possible that we can give drugs for many things? Yes, we can. But might a person wind up on, a cabinet full of drugs? But so it's important that you take into consideration lifestyle modifications. And so eliminating, identifying, and then eliminating triggers. Many of us complain about these lovely things that we carry, and there are things that are not so great about them, but there are things that are wonderful about them. And one of the things that I would tell you is you can find an app for just about everything, and many apps are free. And so if you get a free app, what's the inconvenience of that? Well, you might get an ad or something. There's lots of really good migraine apps. And so you can download an app that will help you look at how frequently you're having headaches, what time of the day you're having, and what things might be triggering them, and help you really look for those lifestyle modifications that can be implemented. Then the other goal is, in doing that, is to push up your threshold for pain. So what lifestyle modifications can you do that push up your threshold for pain? We know that aerobic activity releases endorphins, increases the serotonin in your brain. So that aerobic activity that you do pushes up your threshold for pain. And when we're talking about aerobic activity to push up your threshold for pain, any exercise is good, but unfortunately your brain needs 20 minutes to think that aerobic activity is going to change anything in your brain. So you have to throw out the first 20 minutes. At 20 minutes of continuous aerobic activity, your brain says, oh, okay, I'm going to release those endorphins. And so you really need to go another 10 minutes or so. So it's a challenge. You have to think about, well, what can I do continuously for 30 minutes? And so it might be that you're just sitting in a chair marching up and down. It might be that you're sitting on the edge of a pool, kicking your legs. It might be that you're going for a nice walk, but do you do that walk at 12 o'clock in the afternoon? No, maybe you have to do it at 5 o'clock, 6 o'clock in the morning, or 7 or 8 o'clock at night. So that's important. There are abortive medications for headaches, and they come in a variety of different forms, things that you can get over the counter, as well as things that we can prescribe. And then there are preventative medications for headaches. So we use a lot of anticonvulsant medications for headache management. We use older antidepressants for headache management. There's some cardiac drugs that we use for headache management. And some of you may know that there have been monoclonal antibodies that have been recently approved for headache management. So, and then there's Botox. So you can get Botox for headaches, and you could also get monoclonal antibodies. So there's ways to help prevent headaches if your headaches are significant enough. And then tension type headaches are things that can happen to anyone, and they really respond best to lifestyle modifications. So when we talk about the difference of a migraine versus a tension type headache, some people think, well, it's got to be really severe to be a migraine. No, it just has to have photophobia, phonophobia, light, sound sensitivity, maybe nausea, and maybe some neurologic symptom or on one side of your brain. And it doesn't have to be the most severe headache. But tension type headaches don't have those features. So that's the big difference. They're just nagging headaches that can be as debilitating as migraine headaches. So another common problem for women is bladder dysfunction. And so the inability to store, inability to empty, and then a combination of the both. And so 70 to 80% of persons with MS, and I tell you that is persons both male and female. But I would say for women, that is going to definitely be on the higher of the 80%. And this doesn't mean it's going to be there all the time. It can be intermittent. It's important that if you have these symptoms that you identify those. So symptoms of inability to store would be urgency, the need to go to the bathroom frequently. The feel of you need to go and them frequently going. Urgency and inability to store frequency can also cause some incontinence. And that can be just a little leakage, or it can be a full incontinent episode. And then voiding frequently at night. So what's going on is your bladder has a ability to fill to the full balloon, but you can't store it, so it's continuously having spasms, and you want to empty. So instead of allowing your bladder to get full, it's saying, please empty me, please empty me. And then there's the inability to empty, where your muscles are spasming and will not release and let urine come out. The same thing, your bladder will feel full, and so you'll feel that urge, that need to go, and you may go frequently, but you won't be able to get urine out. You may find that you're in there double voiding, because if you don't, then you're going to be right back again. And you can also have incomplete emptying, where you feel like you still have urine in your bladder, and that can be palpated. And then you can have a combination of these symptoms, which we call a neurogenic bladder. And so really, when you're looking at these things, the key is that diagnosing what is occurring is most important. So it's important that we look at oftentimes bringing a urologist in to help us with what exactly is the problem. So when we look at assessing, we're looking at post-void residuals, which means we ask you to go into the bathroom, void the best you can, and then we will catheterize you to find out how much is left. Again, we can do this either through catheterizations, and we can also do it through bladder ultrasounds. There are urodynamics and ultrasounds. A urology evaluation is the gold standard. And other things that can cause persons to temporarily have bladder dysfunction. Urinary tract infections, number one. Pelvic floor relaxation in women. So as we age, as our hormones change, if we've had children, that can be a problem. And in men, it would be benign prostate hypertrophy. So that impairs the ureter. And so when you look at the management of bladder dysfunction, obviously the goal of treatment is really to ultimately maintain your renal function, because your bladder is the storage for the chemicals that are being excreted going through your kidneys, and then they're just storing into your bladder until you can empty it. So if you don't have good bladder function, then you could ultimately hurt your kidneys. So we want to do that. We want to establish regular voiding patterns, and we want persons to have a high quality of life. So there's not lots of non-pharmacological things, looking very carefully at your diet, making sure you're not taking stimulants in bladder training. We can do EMG biofeedback to help persons with bladder. And then there's pharmacological treatments and prevention of spasticity. We do have antispasmodic medications that we give orally, but there is also, you can get Botox for bladder, and most Botox treatments for bladders last anywhere from 6 months, and some people report as out as long as 9 months. So spasticity treated with Botox can last for a very long time. And obviously, we would want to prevent those things that might make you think you have a bladder dysfunction, the urinary tract infections, and things like that. The other thing is making sure that you're regularly eliminating stool, because, again, the bladder and the colon sit kind of next to one another. So persons who are having constipation may also inadvertently have what they think are bladder problems, and they're really bowel problems. So now let's move on to relationships. So the big question persons think about and often ask guidance from us is, when do I tell people? Do I disclose or do I not disclose? And that really varies from individual to individual. There is a great support when you're able to share with others that you have this disease, because you get support from one another. The other side of the coin is, though, depending upon where you are, that might not be very well received. And so you have to think about that. And do you disclose it to everyone that you are coming in contact with? Well, maybe not. Again, if you're dating, you might want to be clear that this is a person that you want to be around more than just casually before you tell them. At work, there's a lot of things that it depends upon whether or not you're going to tell persons, because depending upon the size of your employer, what your job role is, if you are in a track for moving forward, and there are times where persons who don't understand this disease may look at someone when they say they have MS and automatically think, well, that person's not going to be what I think that person's going to be. And so it's very important that you think about those things. Although you have rights as far as persons with disabilities in small companies, and depending upon where you are, it's extremely important to think all about and think those things through. Remember that once you tell persons, you can't take it back. Once you have said, I have MS, you can't pull that back. The other thing is, you have to be careful if you tell the one person that you think that you can trust, and that happens to be someone in your office, but you don't want everyone in the office to know. You have to be very comfortable in that relationship, very sure that you have been able to tell that person something really, really hot and juicy and enticing in whatever way that might, so that you know that person is going to hold that in, because you have just let out something that becomes, well, everybody should, and they might accidentally tell. They might mean it in a good way. Well, John was having a bad day. Don't pick on him. He's got MS. He didn't mean to be late. He just, so it's very important that you think about that. Whenever you do decide to tell persons that you have MS, make sure that you present it in a positive way. And think about also these things. Why do you want a person to know? And what do you want that person to do or understand about your MS? And what's the best way to deliver that information? And what kind of response do you expect to get? So think about all of those things as you're deciding whether or not to tell someone. And there are many conversations that are difficult to have, and this is definitely one of them. Parenting in MS, the impact on the family, it's important to maintain health and balance and active communication, because MS affects you, but it also affects everyone who is close to you. So if you have MS, everyone in your circle is affected. So it's important to keep that in mind. When we talk about pregnancy and MS, MS does not affect a person's ability to be fertile. And so we tell persons that it's extremely important to know that, because the medications we don't want you to get pregnant on. So because you have MS, you're not going to be any less likely to get pregnant. The majority of women are finding pregnancy to be very protective time, and that is helpful. And there have been studies looking at women who have repeatedly gotten pregnant because of that. And there is some data that was out there before we had some of the drugs that we have now, that actually some persons that were promoting that women stay pregnant their first 5 to 6 years that they have MS. Because that is a protective time, and the repeated pregnancies actually did almost as well as some of our early therapies. So the key there, though, is that, right after delivery, you're a little more safe, but really depending upon your activity going into pregnancy, a month to 3 months out, the risk really starts going up for your MS to become active again. So it's something you and your healthcare provider should have a plan for, is when am I going to restart disease modifying therapy? How am I going to do that? And so it's really important that you think about planning pregnancy. And the ability for us now to plan pregnancies gets easier and easier, because as I look at the options, it's much more difficult. And this is another reason why people need to have a primary care or a GYN, because the amount of birth control options are significant, and all of them have their own benefits and risks. So it's important that you think about that. There isn't a disease-modifying therapy that we have that is recommended during pregnancy. Some are safer. Both Copaxone and interferons are safer, but the others, Novantrone, Gilenya, Tysabri, Tecfidera, Aubagio, Lemtrada, Ocrevus, Mayzent, and Mallinckrodt, are not advocated for in pregnancy. So it's something to be extremely cautious to think about. All of the drug companies have pregnancy registries, so you could call the drug company and find out what data they have. I don't know of many healthcare providers that are advocating persons stay on some of these therapies while they're pregnant, although I know that women in other countries stay on many of these therapies that we would never allow a person to stay on. So I know that there is data out there, but that's something that you and your healthcare provider would have to have a serious conversation about. And know that if you are pregnant, even if you are healthy female other than MS and you're at the proper age, let's say you're young, 25, 26, you are still going to be visiting a high-risk person because they will automatically think because you have MS that you should go to high risk. That MS does not affect your ability to get pregnant, your ability to maintain a pregnancy, or your ability to deliver a child unless you are severely disabled. So just the diagnosis of MS does not affect your ability. So it's just a matter of comfort of the OBs as to why persons get to high risk. So now let's talk about diagnosing MS. Again, when we talk about the diagnosis of MS here, I'm talking about relationships. And so if you can remember back to when you were diagnosed, what was your response? How did you feel? Well, families' responses can be very unpredictable, just as unpredictable as maybe your response was. Maybe it's you never thought you would have done or thought or would have walked out of a healthcare provider's office and said, man, what did they say to me? Because after the first, we were just talking and you weren't able to listen. So it's important to think about that family responses can be unpredictable too, that there is an adjustment, a period that occurs, and this will differ from families to families, so it's important to think about that. You have to think about what your relationship is prior to diagnosis. So if you had a rough family life, maybe you and your spouse are not getting along, the diagnosis of MS is not going to make that better. And so there are going to be challenges. And so it's extremely important that you identify how your relationship was and talk about the ways that you can communicate. So it's extremely important to communicate openly, effectively, and oftentimes, if you're in a relationship or a troubled family, you need to get outside help to have this communication be facilitated in a way that is productive. And then there's also financial concerns because, again, you would have heard from your healthcare provider that this is a long-term, chronic, degenerative disease, and all of a sudden, all of those financial things come up. And every year, insurances are changing, and so that's extremely important that conversation come up, and that will. You may be shaken, but know that sometimes it may help bonds grow closer and stronger. But again, it's through active, effective communication that persons are able to get there. So it's extremely important to be considering that. So how can you enhance the ability to cope with this, both in yourself and family members? The one is to become educated. Really know what this disease is. How can you battle this disease? What can you do about symptoms? So educating yourself is extremely important. Sharing feelings and struggles. Your care partner may know you inside and out, but you're feeling things that they don't appreciate. They don't feel them. And so share with them, help them. And the same thing, the other side of the coin. We'll talk about that a little bit too. So it's important. Set realistic goals and expectations. Is it realistic to say that I'm never going to have a relapse? I think that's an ideal goal. We strive for no evidence of disease activity. But at this moment in time, I don't have a drug that I can talk to persons about and say, you'll never have a relapse. So be realistic and set realistic expectations, and don't try to overload your plate. Seek outside help if needed. Support groups are extremely important and helpful in this way. Clergy, professional counseling can be very helpful. And get help both physically if needed. So if you're having challenges, please make sure that you're also getting those. Explore financial resources. I like to remind persons that this is a rare disease. it is a rare disease, despite the fact that there's a room of you and everywhere. If you went to the MS Walk and different places, there's tons of persons who support, and you may think that they all have MS, but it's a rare disease. And as a rare disease, there are resources that are available to you that are not available to persons who have diabetes, which is not a rare disease, or persons that have headaches, which is not a rare disease. So look at the resources. Go on to MS Views and News website and look at what is it that they have that can help you out. Look into all the other societies and look into other senior services, persons who are at early age thinking about going to college. There are tuition programs that help persons who have disabilities. So it's extremely important. All of the societies help persons who are going back to school. So it's important to be considering all of those things and exploring that. And sometimes that's very hard to know these things. So that's why it's important to connect into a social worker or to ask questions at your healthcare provider's office. Or when you're in a group with persons, whether it's a support group or a meeting like this, if you're struggling with something, tell somebody. I have a patient of mine who I'm telling you, she is a whiz at getting just about anything. And when I have somebody that's got a problem, I call her and ask her, well, how did you figure this out? And so it's important if you talk to persons who have had this, because they may have run into the same problem that you have. And then find new activities for family and friends, things to do together. So that helps with coping. If you're having heat intolerance, well, do you need to go to the beach every single weekend because you always went to the beach before? Maybe you need to go to a pool where the pool is got a shade over it, or is screened in, and it doesn't then get hot, and it'll be cold, and you'll be better, but you'll be in the water and you can play. So look at the things that you can modify activities so that you're still developing that bond. You're not saying, oh, I can't do that. Go ahead, guys, go without me. I'm just going to stay home today. Try to look at things like that. And make sure that you reassure persons in your family how important they are to you. I mean, that should be something that all of us do on a daily basis. Tell people what they mean to you and how they're helpful to you, and how much you appreciate them. It's that goes a long way. So when we look at coping in families, it's important to think about the roles in families. And, today roles are varied, very varied. And many persons may have a thought that things have to be very traditional. And that may well have been up until now, but it's not that way all the time for persons who are healthy and who have no problems. So it's important for you to think about, well, how can I potentially change the roles in my family so that things get done? You might need to make adjustments for just periods of time, or it may be indefinitely. Again, communication becomes extremely important. You need to identify the issues or concerns and look at preferred solutions. Look at ways that you can describe your situation and what may have caused that. Summarize what you could possibly do to change, and describe your key intent. List pros and cons. It's important to try to get as many different options out there. So you might even talk to, again, persons in support groups. How did you handle this in your family? Seek resources that might be helpful, and be willing to negotiate to develop a solution that works. So because you've always done something doesn't mean you always have to do it, and other persons might want to be helpful to do that. So now we're going to switch a little bit and go on to talking about care partners. So persons who have MS, don't close your ears now, but we're going to spend a few minutes talking about care partners. So those persons that are with you. So care partners have some of the same challenges. This is a chronic degenerative disease. It can often cause significant disruption in a person's ability to participate in daily life. That can take a toll on caregivers too. They keep to strive to keep their loved one healthy, that can really challenge them. They feel like they have to lift their spirits. They take on more household responsibilities. So all of these things can mount up, and depending upon the personality of that caregiver, it can become overwhelming. And caregivers' view of this disease is as unpredictable and overwhelming force in their lives as it is in your life. Remember that. You can't predict the future as to what's going to happen to you, and neither can they. So their role changes depending upon what happens to you. So it can become very rocky, very difficult, and again, extremely challenging. So the risk of caregiving. We know that caregivers have an increased risk for depression. There's an increased risk for substance abuse. There is an increased risk for chronic diseases, sleep deprivation, poor eating habits, lack of exercise, failure to treat your own illnesses, and failure to maintain health appointments for self. So one thing can kind of lead to another. If you're at a higher risk for getting a chronic illness and then you put yourself on the back burner because you're going to take care of your loved one all the time, then that chronic illness might even actually get worse. So again, these are things that we know do happen to caregivers. Strategies for helping persons cope. Again, it's very important to relieve personal stress. That it goes without saying, but it's hard to do. So learn strategies that can be helpful to you. Sometimes meditation, prayer, yoga, Tai Chi, and you can use some of these depending upon your stress at where you can just do moments of. So there's meditations that you can do for minute to 5 minutes that can really lower that stress at the time. Sometimes relieving personal stress just means you walk away for a minute. Set goals to attend to your own health needs. Eat properly and seek solutions. Communicate constructively. Ask and accept help. Feel free to talk to a healthcare provider. Again, every time that you are with a healthcare provider does not mean that the whole conversation needs to be about the individual who is there getting the care. Hopefully, if it's a primary care, you share the same primary care. And exercise is extremely important. Exercise helps keep you healthy. It helps reduce stress. So it's important that you have regular exercise. One of the biggest challenges for healthcare, for caregivers, and for persons who have multiple sclerosis, but persons who are caregivers, is that loss of intimacy. It is one of the most difficult aspects of caregiving. Caregivers also feel that the care recipients need emotional support that comes from hugging, touching, holding. So caregivers need that as much as the person who is the recipient needs those intimacies. The important thing is to think about communicating. Think about, if you've lost some of that, how do you get that back? Talk about what your needs are. Encourage, if you're a caregiver, encourage the person you're caring for to be as independent as possible. encourage the person that you're giving care to be as independent as possible. Now, does that mean that you should, am I telling you to ignore your loved one's needs? No. But sometimes they'll feel better if they can do it by themselves anyway. But if you let them do it, they're going to be able to do it longer. But also, if you're letting them do it, that's one less thing that you have to do. So it's not good for you as a caregiver to be constantly overprotective, swaddling, not giving that person who you're caring for the room to breathe, the room to say, let me try. And even if they're going to fail, let them try. Be patient. It's extremely hard, but it's extremely important to be very patient and to let intimacy happen in small ways. So just rubbing one another or passing by or a smile or a kiss on the cheek or a little note. It doesn't have to always be a huge thing. Try to let things nurture and grow over time, and that's better than sometimes, having a heavy hand about that. Strive for balance. Balance is extremely important, so think about that, striving for balance. So keep in mind that this disease, MS, is not a sprint. This is a marathon. It is the race of your life, and you're in it, and I hope that you're all winners. Again, I'm here to answer any of your questions. I kept these slides short so that you would have time to ask.
Who has a question?
Thank you. Patricia, I kind of have two. What's the difference between the ANRP and the APRN? If you can, I know it's education, but as far as treatment.
Okay, so, I was an ARNP until this year. And Florida State decided that I was going to become an APRN. Advanced Practice Registered Nurse, because most of the states in the United States were changing to that terminology, and that includes not only a nurse practitioner, but it also includes a clinical nurse specialist in that. So nurses who are of master's or higher education who have a specialty. So in other states, not here in Florida, but in other states, clin specs are able to prescribe. So that was the term for them. So they just changed we were ARNPs, Advanced Registered Nurse Practitioners, and then suddenly the state said, okay, now you're APRNs. So it didn't change our education at all. And we still are able to prescribe. We are able to prescribe any of the disease-modifying therapies.
I want to know that my feet, they hurt and my toes get cold. That is a question.
So you want me to know, can your feet hurt?
No, they do.
They do.
They hurt a lot, and there's a little numbness, but my toes, they get really, really cold.
So sometimes persons who have what we call neuropathy type of symptoms. So if you think of neuropathy, most persons that have neuropathy, it's a peripheral nerve problem. But there's a central neuropathy, and that is from the nerves that are being disrupted in your central nervous system that are not feeding your feet. So if you have lesions in your thoracic or cervical spine, then you can have an interruption of the sensory symptoms to the ability of your feet to sense. And sometimes that can feel like burning. It can feel like pins and needles. And yes, sometimes persons will describe then feeling that their extremities feel cold. So can that happen? Yes, it can. And what can you do about that, I guess, is the bigger thing is, there are neuropathic pain medications that treat nerve pain that you're describing very well. Anti-seizure medicines are good for that. The depressant medicines, Cymbalta is one, but the older antidepressants like amitriptyline, trazodone are good nerve pain medicines. Gabapentin, Lyrica.
Any other questions? Who's got questions? You guys know it all? You got another question? There we go. Hold on a minute.
Okay. I'd like to know, is it necessary to have 2 MRIs per year instead of 1?
It's necessary to have routine MRIs. And so when I am putting a person on a disease-modifying therapy, I have always gotten an MRI prior, so I know what I'm going to be attributing that next disease-modifying therapy responsible for. I will do an MRI minimally 6 months out to see, how they're doing. The CMSC has said that will be their new baseline, but if I have them on a highly effective therapy and they're having enhancing lesions at 6 months out, we may need to have a conversation about that. Early in MS, in the first 4 to 5 years, I will do MRIs a couple times a year, but minimally once a year. And then again, that also is dependent upon the drug. If I have a person on a very, very highly efficacious drug, my need to monitor MRIs to some degree is even less than a person who is on not as efficacious a medication.
Quick question for you. There are many people around the country that have been told by their general doctors that in rural America that they don't need MRIs but once every 4 or 5 years. What can you tell them?
They need to go see a MS specialist.
And should they be more involved with a comprehensive health care team?
Yes, they need to run away because even the American Academy of Neurology, who set standards and recognized that the standards they set would be what neurologists would be graded off of, said that persons should have MRIs minimally every 2 years. So even if you're looking at the worst case scenario, in MS, persons should be having MRIs minimally every 2 years. But one of the things that I like persons to recognize and understand is that this is a modifiable disease, and we are blessed in 2019 to have so many disease-modifying therapies. And we have to get into the habit of getting this disease treated early and aggressively, because it's only through early aggressive management are we going to stop the disability that's occurring. Once persons are disabled, there is not a drug that we have that is indicated for improving MS. Now, there are drugs that have data that persons have gotten better while on their drug, but the primary indication is not for improving person's symptoms. So the reason to be on a disease-modifying therapy is to change the outcome of tomorrow, not to change the outcome of today.
Another question quickly. Well, it's not a question, but can you please tell the world what they should be doing about vitamin D? Okay, because that's a subject, again, we recently were in a location where a neurologist in a rural area tells them that they really don't need vitamin D, or if they are taking it, it doesn't matter how much they take.
So there have been studies after studies after studies, and the recommendation that persons have a vitamin D level of 70. And so how much vitamin D should you take? I have some persons that take 2,000 units a day and are able to maintain that. I have some persons that are on 50,000 units a day. And I can tell you, the most recent person I did that to, the pharmacist called my office 4 times to tell me that that was an excessively high dose of vitamin D. And I had to, I'm like, want me to give you the lab values? I'm monitoring them. So vitamin D needs to be minimally 60 and ideally 70, but less than 100. You should have your vitamin D monitored minimally every 3 months. So you should have your vitamin D level checked every 3 months to make sure that you are in that range. We know that vitamin D is not strong enough to be a disease-modifying therapy, but it helps the immune system not become so hyperactive. So it is if you want to think of it like a Xanax for your immune system. It helps your immune system kind of be quiet and so MS is one, but all the other autoimmune diseases are making the same recommendation too. Persons who treat autoimmune diseases recognize that vitamin D helps the immune system not be so hyperactive.
Thank you. Next question.
Yes, 2 or 3 years ago, you heard a lot about stem cell research for MS. Are they still doing it, or they just decided it wasn't a possibility?
They are still doing stem cell research. That's a very good question. And I guess what might be why you're not hearing so much about it is that to date, the research that we have done has not developed a protocol that has been sufficient enough to be able to safely give persons stem cells and reach long-term disease modification without such a high incidence of bad side effects. So that there is when you're suppressing someone's immune system completely to give them new stem cells, you can become very subject to getting infections that can kill you. So we are developing protocols for that. And so if you go to clinicaltrials.gov, there are 3 centers in the United States that have research trials for stem cells. The criteria in all of them are enhancing MRI lesions. So don't call them if you don't have an enhancing MRI lesion.
What can you tell us, please? Well, I'll get up there in a minute. What can you tell us, please, about what's available for people with disease progression?
So now, many of you may know that there are drugs that have just been approved in the last 2 weeks. And that adds to the armamentarium of the fact that we already have one disease-modifying drug that is approved for primary progressive. So Ocrevus is the drug that is approved for primary progressive. And we now have Mayzent and Mavenclad, which is cladribine, and Mayzent is siponimod, which are drugs that were just approved for active secondary progressive. So those of us in the neurology community did a little chuckle when that came out. And I don't want you to think I'm being rude. But the FDA said active secondary progressive. How do you define that? So the way the FDA defines that is persons who are still having inflammatory disease, persons who are still having relapses. Many of us in the MS community that see persons already are saying those persons are still relapsing patients. They're persons who are still having relapses. We're still calling them relapsing patients because we've gotten away from saying clinically isolated syndrome, remitting relapsing, secondary progressive with relapses, primary progressive, and primary progressive with relapses. We've gone into you're either progressive disease or you're relapsing. And so if you have a relapsing form of disease, every disease-modifying therapy is available to you. But to that end, that's going to be the struggle that we have with insurance companies. The persons that were in the clinical trials for these drugs, particularly siponimod, was a drug that they tried to bring to market for all secondary progressive patients. And a percentage of those persons in the clinical trials did have relapses within the last year, but not every single one. The drug was shown to demonstrate that persons on placebo became more disabled faster than the persons who were on siponimod. So it's very important for persons to understand, if you have a progressive form of MS, there is not a drug that says you're not going to have any progression, but you are going to progress slower than you would have if you were not taking anything. And that's important because progressing slower means, I don't know. If you're still walking, it means you're not going to be in a wheelchair as faster. If you still have your eyesight, it means you're not going to be as blind faster. So there are qualities, even though you are starting to develop disability, there are qualities of your central nervous system that you still have to preserve. And so therefore, wouldn't it be nice to take a drug that's going to help you be less disabled longer? And with individuals, we can tell about what the group in the clinical trial did, but there are some persons who you may talk to who have primary progressive who are on Ocrevus and say, well, they haven't gotten any worse since they've been on Ocrevus. Well, that's one. But when we look at the clinical trial data, we look at the group of persons. And so there are persons that were on siponimod that one of them didn't change at all in the clinical trial. So it's important to think about, do you have something that you want to preserve? And there are drugs that now have efficacy for doing that.
Okay, we have another question here. And by the way, thank you for that answer.
This was to go back one question. You were talking about stem cell treatments, and I was wondering if you could separate out whether it's like regular stem cell or HSCT, which is I don't remember the name of it, but HSCT, I know that they're offering it in Chicago. Is that any different than the stem cell that, I know that one is removing and replacing your own stem cells as opposed to taking them from outside of your own body. Is there a difference?
Well, thank you for that question. So her question is there a difference between harvesting your own stem cells, cleaning them up and giving them back to you, versus giving you stem cells from a placenta that they harvested, or some other way that we can make stem cells? And the difference is, when you're using your own stem cells, the potential for not having to be on a immune suppressant long term is there. So when you are giving back your stem cells after you have cleaned them up, you need to give them back into an environment that has been cleaned, so to speak. So you need to suppress the cells that are there that are confused, and then you give back cells that are new, that are not confused, and hope that they grow and take over and help. But you won't need long-term suppression because you're not doing a transplant of something foreign. It's you. You will accept that. But if you give someone a transplant of stem cells that are foreign, then you have to think about long-term immunosuppression. And then there's these host of clinics that people go to that they get stem cells from. And I don't know what they're getting. I mean, I've heard from people that are going into shopping malls and getting an IV infusion and tell me that they had stem cells. I don't know what they got. They're closing a lot of those places down. But that's very costly. So I would say do something that's got some proof behind it.
Let's all say thank you to Tricia for doing this tonight.